so we can share this with those that couldn't attend. To everybody that's here, there'll be more joining us as we go, I'm sure, but we're up to close to 40 now. I'm Jeff Davis. I'm the Interim Director of Executive Education at RIT, the Saunders College of Business. We have an Executive MBA on-campus program, an Executive MBA online program, and customized corporate programs that we do with companies local and across the country. So what we're doing, and we had one of these last month, and we're going to have one next month, is we're trying to create a bit of an experience of what the Executive MBA program is, which is let's have a discussion around topical items and get some experts in there to talk about what's happening in those spaces. And those conversations become so engaging that our students revel in that experience. And they actually miss the program at the end, partly because of that engagement. Sitting at lunch and talking with faculty and leaders in the industry to find out what's happening, to discuss ideas around what's happening. Last month, we talked about governmental policies and their effects on business. And it was a very interesting conversation. And we had a good audience and we had some great engagement. And so this month, we thought we'd go into healthcare, especially with what's happening with the pandemic. A lot of massive changes taking place. And so the future of what that means to us is interesting and intriguing to us. So we're going to have a discussion around that. And by the way, we haven't put it out yet, but we're going to have another one of these next month. And we've got a couple of topics we're weighing down, but we'll get that information out soon. So the goal here is simply to have a good conversation, to learn something, to get engaged. There is a chat bar, so if you'd like to ask questions, you're welcome to put them into the chat bar. We will try to get to them. At the end, we'll certainly open up for a few questions. So here we go. First, let me introduce to you who's on the panel. You can see them on the page here. David Krusch, VP of Applications IS&T, and a surgeon at Rochester Regional Health. Matt Phillips, Vice President of Health Informatics at Rochester Regional Health. Matt is also a alum of the program, the EMBA program here at RIT, and an adjunct faculty member for us. He's currently teaching one of our exec ed programs in service technology. And then Katherine Schantz, Senior Director of Clinical Informatics at Rochester Regional Health, and Scott Stratton Smith, Informatics Medical Director. So thank you all for joining us. We're very happy to have the expertise you bring to us. And let's see what we can do. So I'll start it off with a very general question, just to get people talking. And the first question I'm just gonna ask is, can you give us your thought on something that's been taking place as a result of the pandemic that may lead to change going forward? And I'm gonna open it up to David first, since he was first on the list on the page. So David, just something that's happened in this process that you think might lead to change in healthcare as a result of what we've seen.
Thanks, Jeff. I really appreciate the opportunity to talk to you guys. And I think what I'm going to talk about, I think Dr. Stratton Smith can work collaboratively with me, because Scott, being a primary care physician and family physician, is also one of the medical directors in charge of our patient engagement initiatives. One of the things we've seen is we've seen a rapid uptick in virtual care, telemedicine. We were just reviewing some statistics with Epic, who is the sponsor of our electronic health record, the other day. And prior to the pandemic, and now during the pandemic, we've seen, believe it or not, 167,000% increase in the use of telemedicine or video visits. And when we talk with the project managers that's been working on it, he said he's accomplished in the past 4 to 6 weeks what he intended to accomplish in 3 to 5 years prior to this. So we've become very good at it. We've become good at telemedicine and video visits, and just the patient portal, which we call MyCare, which is Epic's MyChart. We are beginning to enhance it to the point where we are going to offer our patients a tremendous amount of complimentary opportunities to have a touch-free visit, that when they come to see a provider in person for an office visit, when that's needed, or for surgery, that everything to do with the prior to the visit activities that would otherwise previously have been done on paper or in person can be completed electronically. So we're just about catching up to the banking industry.
Pretty amazing. And I'm imagining that's going to have some massive efficiency results at the end of this.
Well, think about things. So I as a surgeon, in my part-time, I do some surgery. I'll see patients obviously preoperatively, but post-operatively, we have a follow-up. And the follow-up is part of what we call the global experience for the patient. Now, sometimes that patient will travel an hour, be seen in the office, go through the registration process, the arrival process, and be seen for 5 or 6 minutes post-operatively, and then turn around and reverse the process. So they've taken 2 or 3 hours out of their day. And is that really necessary? Should we have always been doing it differently? So the pendulum is going to swing, but it's not going to swing back to where it used to be. Maybe some of the silver linings of this cloud is just catalyzing us to do things more efficiently and better in ways that we always should have been doing. Scott, I don't know if you want to add to that.
Yeah, I would echo everything Dave said, but I would also add that for those of us in the trenches of primary care, I think we all feel like this is the biggest change in medicine other than changing from paper to an electronic record. And it's all happened very quickly. And, just a few weeks, we went from seeing every single person in person, face to face, human contact, to I have whole days where I see no patients in person at this point. I think I've only seen 3 this week. Face to face, and everybody else has been virtual care or telemedicine. And it's just the shift of using the technology that we've had available, using it to its fullest capability, and so for the provider to manage the electronic record. But then so much of this is on the patient's end, to make the video work, to make the microphone work, to make the sound available, and getting that to stay there through the visit is the newer, bigger challenge that we face. Often the visit will start and then the internet connection goes down, or the sound disappears, those sorts of things. And that's the real crux of guiding a patient through what's not working. Can be really difficult for us, but we're all learning. So it is getting better, but none of us would have predicted us to be in this place back in January.
So,
Can I field Scott's question, Jeff?
Yeah, which question?
Scott Strother, is a change a good thing, a challenge, or both?
That's what I was going to bring up, so good.
Okay, sorry, I'm monitoring them too. I've caught up with a couple of friends on the side as well.
Nice to see you.
Hi, everyone. So the question, is it a good thing, a challenge, or both? I think it's both. I mean, it's a good thing because the absence of care is not a good thing. Our volumes with, the ambulatory setting that Scott's in are about 70%. So it's a bad thing of what it was pre-COVID, but that 70% could be much lower and we couldn't be accessing and getting care to patients. It's a good thing because we were able to rapidly turn it around. We were able to get that out there, and Kate could probably speak to eventually, a lot of the government mandates really switched and pivoted quickly to help reimburse for virtual care. It was not ready, it was not aligned, and really, I mean, we were doing it with or without that because it was the right thing to do, but you're going to see insurance and other things start adapting and flexing to this type of thing. The thing Scott loves or hates about me, because we're working together, we're colleagues, is I like to ask questions on the data and the metrics though. And, oftentimes he's like, oh, hold on, I'll research that, get back to you, because I'm curious. And one of them we just discussed today was no-shows are way down with virtual visits. And that's a very big challenge, both for continuity of care to our patient base, but also, the operations of a health system. If someone doesn't show, it's a wasted opportunity to treat someone else, and it's lost revenue. And they're assessing the impact of this to hospitals and health systems is about $200 billion this year. So, I mean, us, like much others, are going through cost-cutting measures and everything else. So we're able to, with this, kind of deliver better care, deliver care where there may not have been some, and lessen the financial hit, not mitigate it completely, but lessen it to an extent. So it's kind of a win across the board. But Scott, it's definitely not been a easy thing to turn on. It was a momentous change. I really, the physicians rallied around it, and physicians are not always the easiest on change management. I love you guys, but it's a challenge sometimes. So, I think it's just the perfect storm to turn this on, and that's probably one of the silver linings out of this. So I don't know if that answers your question entirely, Scott, but that's my reaction to it.
Jeff, do you mind if I add a little bit to that?
That's great.
Okay, so Matt, you said we're at 70% and we're increasing. Hopefully, This will be a more patient-friendly and provider-friendly way of delivering care in the future. And maybe we just won't return to 100%. Maybe we'll turn to 125%. Maybe those patients at home that couldn't drive 3 hours for that post-operative visit will be able to get that care in the right setting at the right time. And we may be more effective than we were before.
So actually, I was going to go to Kate, but if you hold on a minute, Kate, I want to add on to this just a little bit. So we mentioned here the efficiency that this provides and the ease of access for the patients. How about from the employee side? So are we're finding, just like everybody else, I'm working from home. I'm sure many of the people that are attending this today are working from home right now. That doesn't always work, but when you're doing much more telemedicine, is there an opportunity for a lot more of the physicians to be doing this work from their homes as opposed to from offices? And are you finding most of your employees doing that, or a good percentage doing that? And will some of that continue going forward?
Jeff, who's that to?
That's to any of you.
Okay, so I know there are plans in the future as we start working towards expanding our network and everything else. We may not look at putting up as many primary care sites. We may try to create this hybrid model to expand our reach. And one of the biggest costs is, on top of labor, or besides labor, is office space, is buildings. It's that sort of draw on our resources. And if we don't have to do that and can provide better care and access, I think that it is on the radar going forward, especially because I don't know how quickly we're going to recover from this. We are looking to start up elective surgeries soon, but there's an awful lot of business that's been paused. And I think the other challenge is we're even trying to anticipate if there is a delay in all this care, there's a potential bubble, right, of care that needs to be done. So it's, preparing for the COVID surge, unsurging, looking for the next surge in potential care that's been delayed or held off upon. But yeah, going back to the original question, I think we're going to look at things very differently going forward.
And I think the patients will be also. I think the patients are going to have a new level of expectation of the way that they can engage with us as a health system. And I think hopefully, coming out of this, patients are just more in tune with their own health. We have the patient portals and the different ways of accessing their information and engaging with their providers, which hopefully will help with preventive medicine down the road too.
Excellent. We've actually got some more questions. I'm going to throw them out there. And if any of the four of you want to respond to these, that would be great. One question, will healthcare professionals be reimbursed the same exact rate for telemedicine or televisits? And you might have the answer to that.
I think they're trying to get there. There's been some recent regulations, I believe, coming out where they're trying to determine, what that face-to-face visit, and will it be reimbursed the same? Scott, I don't think it's exactly one-to-one match right now for televisits versus when a patient's in the office, but I think there's been some conversation where they're looking to almost get to that point where they would reimburse the same for a face-to-face visit, even if it's done via technology.
That's right. If it's a video visit, so you can see the patient on whichever platform, those can be, the billing can be the same as if they were actually in the office. If the patient does not have the technology to allow for a camera or a video visit, then the telephone visits, depending on the insurer, are reimbursed at a lower rate. But many of the insurers are now, because of the COVID pandemic, they are saying, okay, we will allow for the billing to be the same as if you saw them face to face in your office. So there's some nuances in that, but everyone's recognizing this is the way we're going to offer medicine, at least for the short term, if not the long term. And so the reimbursement rates have gone up.
There's another question here that's interesting. It's around, do you anticipate patients looking for experts in specialties rather than deferring to the hospitals that are close to where the patients live? So in other words, the effect of telemedicine on regional or local patients.
So I'll start that, and I don't want to have, it taken over completely by me, but I can say that, part of our strategic roadmap before all this was looking at some of the risks and threats and these so-called destination medicines that other places were setting up. We are very much trying to explore that for some of the areas we are are good in. You know, I'm not going to disclose which, but I would say that by and large, it is something that we were trying to pay attention to and be cognizant of, because otherwise that's going to potentially cannibalize our ability to help patients locally and or nationally. I think we can further accelerate the plans based upon everything that happened here with remote video visits, you know, even just covering across New York greater with telemedicine and all of that. So it was definitely, you know, when you do your SWOT analysis, it was one of the threats to us or an opportunity, Jeff. So you know, the answer to the question is yes. We weren't quite there yet, but this is going to probably put us closer to there than we would have been otherwise.
Yeah, Matt, I agree with your assessment. There's a little echo. There, it might be yes, but. So one of the ways that medicine is evolving, even before this happened, was it was evolving away from an individual specialty or department approach to a program approach. And we have programmatic or service lines that are dealing with disease processes rather than individual specialties or individual providers. And we provide this as a comprehensive offering. So for that comprehensive offering, staying within the collaborative program is probably going to benefit the patient more in the long run than diversifying or fracturing that care geographically.
Yeah, I'd agree with what Dave said.
I agree.
Okay.
Yeah.
So Kate, I kind of skipped you on that first question, and which is back to, you know, in what ways do you see change coming as a result of what we're experiencing right now?
Having a little bit more of the data reporting background aspects in my role, I'm hoping that internally organizations start to see the value of data and how they need to use data to drive strategy and planning. So in certain situations like this, you know, Matt had a great plan in place where they were working on more of a predictive model to determine when the surge might hit. And I think having that access of data of knowing, and thankfully we have the electronic medical record systems to help with that, capture information discreetly to show, you know, bed availability, capacity, and be able to roll that up and summarize it to the state level, to the national level. I'm hoping that people really start to see the value of data and the power with that. And I think there's a lot of artificial intelligence that can start to be leveraged in situations like this and predictive modeling. So I'm hoping that kind of keeps that in the forethought of people's minds for the power of data with all of this.
So when you mentioned attempting to predict the surge and attempting to use the data to identify what was happening, you know, we see the news and most of us see the typical stats they're reflecting, which are, you know, death counts for different counties or new cases announced, hospitalizations. What are the data points that are most intriguing and powerful to you at RRH? What are the things that you're using to help prepare you for what's coming or for a future occurrence of something like this?
Matt, I know you've been more involved with the model. I know my group, we're actually more looking at some of the patient-specific data points. So we're actually abstracting all of the COVID positive patients that are coming through the health system, more from a research descriptive analytics standpoint to see if we can track and trend things that are happening more from the clinical course of patients. And I know Matt's been more heavily involved, so I'll probably punt that question over to him on the surge planning.
I was going to punt some stuff back to you, so I'll do that later. I think, Jeff, you know, it's a myriad of different models out there, and it's always a challenge, right? Which one best fits the region, the demographics, you know, the rate of growth versus the impact of social distance. So we've explored a lot of those, and we've tried to come up with different modeling, you know, not dissimilar to what's on the news, but it's more what we're doing with them that doesn't make the news. And what we're doing with them is we're working with Dave and his IS&T partners to basically anticipate or forecast forward, you know, 4 to 6 weeks. Do we need to make any medical record changes? Do we need to turn any floors into ICUs, you know, ventilator allocations, stats on that, and plan forward. We're using it for modeling our ordering of PPE, personal protective equipment. We're even using it for, you know, working with the state to prove if we have a rolling average that the cases are sustained, you know, can we start doing elective surgeries? So I think what you're seeing on the news is, you know, it's something we're all looking at, right? But we're trying to take it to best estimate our operations, you know, safely provide care back to the community, but also keep ourselves fully prepared for if something does happen as we start turning that dial back, as Cuomo said. So it's not going to be a light switch where things are normal. It's going to be a slow turn of the dial, and we need to make sure that along the way we're modeling and anticipating kind of anything from supplies to IS&T needs to even staffing for those.
So with that mention of elective surgery that you brought up there, we talk a little bit about, I think I heard Unity has opened up for elective surgeries already, but I think I heard Rochester General did not open right away with elective surgeries. Can you tell us what's happening and if they're expecting that to take off? And if they do, how quickly is elective surgery going to pick up in the area?
So are we expecting it to take off? Yes. There's some stuff that I can't disclose yet that I found out this morning, but I would say soon. You know, we're typically, I think, let me spin this back to, you know, how we measure data, right? So we typically run our hospital at an overcapacity because it's just the way we've done it and the way we've had to utilize our resources with a finite amount. So typically we're like, and Dan Chan is one of our ED docs here, we typically have an ED volume of 150 to 200% of what is considered normal occupancy. And we efficiently see all those patients, we get them through, we triage them, we get them to the floors. But 100% is not normal for us. 150 to 200%, that's pretty normal. Now, the interpretation of the surgery and, you know, that assumes 100% capacity, which is something we're not used to even operating in under normal days. And, you know, we need to make sure and make the case that for that, we show that we could safely potentially operate in excess capacity and apply for a waiver for Rochester General. So, you know, those are some of the things that are moving behind the scenes, because this is a hospital that's typically, there's 4 levels of overcapacity, and it's almost always sitting in level 3 or 4. And, you know, we still provide good quality care. We efficiently get patients in and out, but it's just the nature of, you know, the community we serve, the amount of beds available to the community. And I'm sure our colleagues across the way at URMC also experience similar capacity challenges. So the assumption of 100% and having to save 30% capacity for potential COVID surges puts you at 70% available. And when you're normally operating at 150%, it's pretty hard to get things up and running. So that's some of what we're navigating through and towards. But again, that's using data to tell the story. And this is something we track daily.
And how has Rochester Regional Health dealt with the challenge of, you know, if you're not operating those elective surgeries, which is a major component of your bottom line, I'm sure, and you're not running those, you've got employees that are not being used for their specialty. I'm sure there's been some reassignment, there've been some furloughs, maybe there've been some other approaches. Can you take us through a little bit? And I know you aren't the ones making these decisions, but you kind of understand what's been happening maybe. How have they dealt with some of this, and how does it look as far as retaining all of those people and bringing them back to where you were?
So I think, you know, we haven't had to furlough anyone yet. We've been doing a few actions to try to avoid that. I know my wife's organization where she works, you know, she's getting furloughed for a couple of weeks because there are enormous cost pressures, right? We're trying to go at it a little differently. We're looking at how much we can do ourselves. We're trying to cut contractor costs, you know, avoid consultants, do away with the potential for agency nurses and clinicians. So we're trying to really take a good hard look at our costs and mitigate those, do it ourselves, do it well, do stuff that you might not be normally used to, but step up to the plate in order to do that so that we can protect the jobs in the organization. Along the lines of redeployment, yes, there's plenty of that going on. You know, as we see different areas that have needs, and if you have someone that's job didn't work in the organization in a COVID type of world, we do try to find them gainful employment before getting to the point of looking at cutting positions. I can tell you we're not currently hiring, and all open recs were closed, much like other places, but we are trying to basically protect the family, so to speak, and rehome people as much as possible before any of that. And then, you know, taking a good hard look at our costs and, you know, what we can do without from a consulting contractor standpoint. Dave, I know you're at the thick of it on the IS&T side. Is there anything else you want to add?
I think you said it very nicely. I think we're moving to an agile and nimble type of usage of our very valuable people resources, and what we can do to help others, what we can do to cross-train, what we can do to be all hands on deck and chip in where needed, when needed, and as needed, is the way that we're working to preserve our family.
I can speak firsthand to that. So my wife is a physical therapist who was employed by Rochester Regional Health more recently as they acquired her company. And she's working in a nursing home in a role of, I'm not sure what the official role is, but it's almost like a certified nurse, a CNA. And that's to keep people working, but also to help provide help where they're missing people, right? They've got people that aren't in work, they need help. So it's a good way to cover both bases. Challenging, certainly, to everybody involved, but there's training happening, and there's still the opportunity to continue working. So I see that firsthand. But it also brings up the other question, which I'm curious about, because Rochester General, and I'm going to go back to the old name, right? Rochester General used to be a large hospital with a lot of departments and a big area to manage. And now they're Rochester Regional Health. And they've got hospitals in Batavia and Clifton Springs, and I'm not going to name them all, but there's 5 altogether. And they've got long-term care facilities and outpatient clinics and rehab and all of these different facilities that all came in with their own procedures and programs and processes. And it must be really challenging in a time like this when you have so many places that are used to dealing with this in their own way, or used to processing and handling things in their own way.
Can I volunteer someone?
Yeah.
All right, Scott, I'm going to volunteer you. I think primary care is a great example of a hodgepodge of acquisitions and different regions and different assumptions, medical records, everything else. So how do you sift through that and kind of, I'd love your insight on what Jeff's question is, because I think you live and breathe that.
I do, that's true. And I think that if anything else, a pandemic brings that sort of unified approach to things to light. And I think that across the practices that I'm familiar with, we've all strived to do things very similarly with shifting protocols. And as I'm sure you're all aware, week to week, almost day to day, there were different thoughts around what's the best thing to do around managing patients. Should we be bringing them in? Should we keep them out? Should we swab them? Should we not swab them for the flu? That was one of the original problems. And I really think that if nothing else, this pandemic has probably brought a very disparate group of practices that stretches from Batavia to Clifton Springs, probably closer to doing things the same way than we ever were before, just because we've all had to adapt so quickly to these changes that were thrust upon us. So it's kind of interesting. I hadn't really thought about that, but I do think that there's a more unified sense for all of us. We're all in this together. We're all trying to learn very quickly. And one thing that has happened in the primary care world is we have now 3 times a week, but it was 5 days a week, huddles where all the practices across the system could raise questions. It was a huge Zoom meeting, 250 participants, and we would all hear each other's questions. How are you managing this? What are we doing here? Et cetera. So again, it really brought a lot of people that may have felt that they were in their own island of care into a larger continent of care.
Jeff?
Yeah.
I think I would like to echo 100% what Scott said. And when you think about the way we have begun to structure ourselves, to be effective as a health system at this point forward, or maybe even before this point and moving forward, we have to have a system approach. So they're not going to be 5 facilities that are 5 separate islands of care. It's going to be one system, and we will use the provisions and the resources effectively to benefit the system, to benefit the providers, but most of all, to benefit the patients. And when you talked about opening up elective surgeries and how early Monroe County wasn't even open as a whole. And then we began opening hospitals in Monroe County, and we attested to the issues that Matt raised. Early on, well, I would say starting on the 29th when we started opening elective surgeries, even before then, some of the remote facilities, such as in Batavia, such as in Clifton Springs, such as in Newark, we were triaging appropriate cases to those hospitals so both the surgeons and the patients could get their elective surgeries done by using Rochester Regional as a system approach to benefit the patients rather than saying just because you're traditionally a Rochester General, you're going to stay traditionally there.
Excellent. Thank you very much. We have a question from one of the attendees, Scott Struther. Can you speak to how hospital and long-term care settings are dealing with the psychological effects of no visitation? I don't know if anybody's got an insight into that, who that might go to.
Probably our two physicians would be the best equipped to answer that, but you know, I don't think either of them operate in quite those capacities, but would you two like to take a stab at it?
Well, I've seen the struggles of the family members who have someone in the hospital and their fear of sending someone to the hospital. So certainly there have been some reports about this, but I've seen it in my own practice where patients, their families are very reluctant for them to go to the hospital at all because they know they won't be able to see their loved one face to face. Certainly, they've tried to rely on, I know one patient of mine that had stroke symptoms. His wife made sure that he took their one cell phone that they had with him into the hospital so at least he'd be able to communicate with the family as, you know, he went through the steps of the care that was needed. So I've definitely seen the stress and struggle on the family side. It is true I don't see patients in the hospital, but it's certainly a challenge for everybody. And the isolation of the whole pandemic is definitely something we're aware of. A couple of the people I did video visits with yesterday had not left their home in 7 weeks.
Yeah, I mean, I'm stir crazy. I have a little one, no daycare, and you know, there's the doing the right thing and staying home, and the fear factor of going out. But you know, I also experience the flip side where I get stir crazy, Scott.
Yes.
So.
Yes.
You know, just before we leave that topic, you mentioned the fear of coming to the hospital, and I just want to add that that probably is going to have an effect. I'm sure you've got this figured out, but to the people coming back in when they open up elective surgeries in RGH or in other facilities, that there still is a fear for some people to be in the hospitals at this time, right?
Yeah, and Jeff, there's also the risk of, and we haven't seen this unfold, right? But if they're delaying care and it's something that's potentially severe, it could get worse. So whereas you could address a more acute or minor issue, it could potentially become a chronic or a long-term issue. And I think that's you know, we need to make sure that we reassure the public things are safe. It's okay to go in. You know, it's we're taking the precautions. As Dave mentioned, I'm gonna go full circle back to what he and Scott are planning. You know, the touchless visits, basically illustrating to the general public, hey, you know, we don't want to delay your care because of these risks, but here's all the precautions that are being taken as well.
So,
And I think,
go ahead, Kate, I'm sorry.
I was going to say, and I think the visitor restrictions make that a challenge too, because if you think about the emotional state of patients, you know, usually you're going to the hospital, you're more comforted if family can be there with you. But just due to the scenario that's in place right now with visitor restrictions too, I think that's even, it will make patients even more anxious, you know, kind of going in almost alone, if you will.
Yeah. So Kate, I'm going to ask you a different question, if that's okay.
Yeah, sure.
I know you work in the government plans and mandates side of things, and I'm curious because when we see a crisis like this, the government often acts very quickly, when at the rest of the time, the government does not act quickly at all. And so I'm curious if you see that there's changes happening in the way government processes things and the way that they might make changes, and if that's going to continue to happen, or if this is going to be simply, we had some things that addressed immediate issues and we'll go back to like business as usual after this.
Yes, I do have to say that the pace of change with CMS has really been wonderful. The way that they address this, from the interim rules that they're pushing out.
Kate, what is CMS, just for those that are potentially naive?
The Centers for Medicare and Medicaid Services.
Okay.
And the Health and Human Services, the higher entity that they report up through in the federal government. You know, just everything from how they're paying for televisits, to postponing and recognizing unnecessary things that have to happen. You know, they're not coming in and surveying hospitals in the way that they ordinarily do, so that we can put our resources where we really need to in a time like this. So I think that the pace of change with CMS at times can be very slow, you know, year to 2 years to get change implemented. And they really push some stuff out fast, in a couple of months. And even with dispersing the provider relief funding as quickly as they did, it may have been a nightmare to submit the data to them so that they can make that determination for who gets what. But for them to distribute that money in the manner that they did and how quickly they did, that was great. And I think it puts pressure on the payers too, the commercial payers who often follow suit of CMS. So, you know, they're having to keep up the pace with things. I think what's going to be tricky is how fast change happened in the past couple months, and is that going to be the expectation going forward, and how fast CMS will be able to adapt to things in the future, if as they did with COVID.
You know, we talk about how fast things happened and how quickly things changed. Clinical trials are being upended, right? The whole idea of how clinical trials are performed, there's good and bad to this, we understand. And we know that we're hearing nightly about new vaccines that are already in testing on humans, and we're hearing about, you know, maybe relaxing what would have been normal standards in the approach to this. So any thoughts or concerns on the impact of that on the industry and what that might do longer term?
High level, I would, kind of from a non-clinical perspective, I think we do have to balance that with, as changes are pushed out, they need to be pushed out in a way that the nation can adapt to them, because a lot of the stuff that comes out from the government, it's big sweeping changes at times, and it can take organizations a year to implement something to meet that regulation. So I think they do need to do that thoughtfully, in the way they do that. And as it relates to clinical trials, there's some things that just can't be rushed. And, you know, I think they do still need to have their due diligence in following the phases of the trials and how they move that forward. Because, you know, it's then you're getting down to the human element of that and impacting an actual person's health. And probably Scott or Dave could allude to that further.
Yes, I mean, I agree with you, Kate. I don't want to let rushing certain therapies to market get in the way of good, sound science and the basis of that for clinical trials, because some of that sound science not only gets the therapies to the patients in the time that's needed, but also protects the patients from getting therapies to them that may have untoward consequences.
I would echo that, and I would just add that we are spending quite a bit of our day, a measurable percentage, where we are countering what they've heard, whether it was through Facebook or Snapchat or whatever source of media, that people have this idea that antibody testing is readily available everywhere, or that we're only a month away from a vaccine. There's just all sorts of things that we have to sort through with patients. And I often say to patients, similar to what Dave was just saying, you know, we have to rely on the science. Let's rely on our scientists, and try to break through that noise of there's so much information being thrown at all of us, and it can be difficult for patients and even for ourselves to sort through.
The other thing I'll add on that is, and I'm going to take a little different path than the initial question is intended, so apologies in advance. But you know, we are doing a couple of clinical trials, and we're doing stuff, I think, not just as a system that we have wanted to do and we're ready to do, but we're doing it now. So we have, and it's out there. It's, you know, there's active calls for the Pfizer study we have on a potential vaccine where they're testing RNA sequence. So we're looking for volunteers. You know, we're doing it. We're stepping into it quickly, but we're still going about it, as Dave said, with a science-based approach. So it might accelerate getting the vaccine to a potential state where you can do clinical trials, but we're not compromising the clinical trials. And I think the other interesting thing, and this is where I wanted to take it, was this is something that, you know, you think of us, you know, we're in it for the community, we're in it for all of the health of the Rochester region and beyond. And, you know, we do have a little competition across the way, but it's turned into a lot more co-opetition. So this is a partnership with the URMC on the clinical trial. We're taking different parts of it. We're doing it together. There's an app that's rockcovid.org if you want to Google it. And in about 20 minutes, Mike Mendoza is going to go and talk about it as a press release. And we have both leaders, physician leaders from both systems on it. It's a joint partnership, and it's, you know, how do we kind of try to start tracking and getting a idea around symptoms. And it's a simple chat bot, but, you know, it's something that a lot of people are interested in leveraging. And if this could potentially be a tool to also do that in place of tracking and other things. So I think I'm just kind of segueing a little bit to a shift I noticed from the clinical trials, but in general, you know, we're there for the patients in the community, but it's turned even more from competition to co-opetition at this point. So we're in this together.
Thank you. So you mentioned a couple of times about the fact that you may be opening again, you know, I say opening again, you're open, right? But you may be opening up to elective procedures. You may have more people coming back into work that were working from home. Give us an idea of what that might look like. What it will be at RH? What are some of the changes that they'll notice? Are there going to be some testing happening for people coming in? You know, what is the expectation going forward?
Scott, do you have to do the daily pass every day?
I do, yeah.
You
So
probably should take it from there.
Yeah, so we have to check our temperature, and we have to go through a series of 3 questions. Do you have a cough? Do you feel short of breath? Have you had a fever in the last 24 hours? And every employee here has to show our manager that we went through that, and we have a green pass to go ahead and start our work for the day. The other thing I was just going to mention is that we no longer, just one thing that you may not be aware of in the outpatient world, to protect our patients, to protect ourselves, a patient does not just walk in the door and sit in a waiting room. They call the office when they arrive in their car, and the access associate or secretary checks them in. The nurse goes out to their car, escorts the patient directly to the exam room, and then they're of course masked, and then the provider sees them with a mask, shield, and gloves if needed, depending on their symptoms. So it's there's no sitting around anymore, and the patients leave very quickly too. And many offices have a ill side of the office and a well side, or they're trying to do scheduling where well visits are early in the morning with elderly folks, and then later in the day, you bring in the patients that might be sick with, say, a fever.
And Dave was, you know, we were working through not just IS&T, but in general, you know, the work from home regs before this even happened to make it a little bit more appealing to employees. And, you know, I think there's questions around, do you need so many people to come back to work at once? You know, can you operate remotely from a support services side of the house, not on the caregiving side? I mean, caregiving's obviously got the virtual visits and everything, but, you know, support services, I think trying to operate in this new normal, it might not change back to, you have to get to work, you know, 5 days a week.
And Matt, that's very well said. I think we're gonna have to, as Matt said, right before this happened, we had put into place a work from home policy for all of our IT shared services. And I think we learned very rapidly that we could be very effective, if not in some cases more effective. Some of the employees drive an hour each day. That's 2 hours of non-productive time that could be more helpful for them and more helpful for the system as a whole. So as we begin to go on unpause, for lack of a better term, how will we use what we've learned to be more effective? If some of the workspaces are not within the required social distancing spaces, should we now have alternate days that people come in? Can we be more effective with the use of the employee's time? Can we be more effective with travel? And can we be more effective and safer with the space usage, where at the same time maintaining or surpassing our ability to be productive?
I think one other thing or a facet of this that's not being discussed, but and it's not related uniquely to us, it's across the board, is if schools or daycare aren't open, you might not get people that are able to come back to work either. I mean, that's another constraint. You know, my wife and I are both working. We balance childcare. Kate, you know, I saw your daughter come in, and hello, and you know, trying to teach, work, all of that paradigm. I don't think, even if you want to go back, some of this won't be fixed until some of that gets addressed.
And I talked to a local company, a pretty good sized company, that said that they're expecting after this is all over, that they're only going to have about half of their employees in the office. And that's not because of that's not as a result of concern about the pandemic. It's more that they've learned that they can be effective remotely. It saves them a lot in other aspects, and it provides better quality of life for a lot of their employees. These were some of the reasons. Now, at a place like Rochester Regional Health, I imagine the number can't be anywhere near 50%, but are we talking, you know, support services and, you know, whatever number, is that 10% of the staff? Is that 20%? Do you think that's a big chunk?
I mean, it's not a inconsequential chunk. We're what, around 16, 17,000. I think we're over 17,000 now with Lifetime, with your wife joining us, employees. And I would say shared services, again, don't quote me on this, but I think we're at least a 10% chunk of that between finance, human resources, IS&T, purchasing, you name it. So it's not an inconsequential amount, but our largest workforce is by far our nurses.
That's a big number, though.
Yeah.
It's not a different topic. Again, you mentioned face shields, and I happen to know, first of all, I'm looking at the screen here, and I see Tony Smith has joined us. Tony's at General Motors. General Motors was out there making ventilators for people, right? And then I know that you mentioned face shields, and I know Century Mold is a local company that made something like 50,000 face shields. Did you have a lot of new partnerships? Did you find RRH found new partners in this relationship that are giving them what they need and have been meeting the needs for the system?
Partners and I mean, volunteer and kindness as well. I mean, you know, I don't know that it will last indefinitely, but you know, Hickey Freeman made masks, and you know, all these repurposing. We have quite a bit, and you smell like an alcoholic, but of the hand sanitizer from Black Button. I mean, it's fantastic. Yep, there you go, Scott. So that's why he's always so happy. No, but I see a lot of it as it is new partnerships, new channels of supplies and everything. But you know, how long will it last? You know, when companies need to go back to their normal operations and everything else, I think that's a risk as well. And it's been an awful lot of goodwill.
Well, I did hear from at least one of those companies that they're considering starting some new lines in PPE because of the concerns of overseas supplies and what we need locally. And so anyways, it is going to create some change in industry around the area, I think.
Mm-hmm.
I have a question from one of the listeners. Tara Shedlovsky asks, as non-medical companies are starting to anticipate what a return to work looks like, do you see a medical consultant opportunity to help companies make these decisions that the local medical experts could lead?
I don't need to answer this, but hi, Tara. She's one of the master swimmers with me when we do normally swim in a pool. So just wanted to say hi. Okay.
I know that there has been a lot of conversation around that. I know just our Hospital Association for New York State just held a webinar yesterday about kind of what that return to work would look like, and even down to the manager level, managing, you know, your kind of lowest level analysts, you know, just in terms of what that relationship looks like and how you do that remotely. So there's definitely a lot of conversation starting around that, because you know, it's always I think it's the worry initially of a manager of how productive is your staff going to be working from home. I know I've seen with my staff that should never have been a worry. I feel like they're being even more productive and more engaged. But I think it's, you know, how do you still make them feel appreciated? It's using different communication methods and techniques, and kind of understanding that, you know, if you're only seeing verbal and not seeing any visual cues, you know, is the person really getting it? You know, I think we've had some instances, Matt, you know, even on our team where, you know, just making sure that people have clear understanding and expectations coming out of a conversation. And maybe if it had been done in person, they would have had a totally different take on the conversation versus just over the phone. So I think there's there's a lot of work to be had there to get managers and staff used to what that working environment will look like remotely.
But I think, yeah, I agree, Kate. But I think medical consultant in a non-medical company, yes, I think there's opportunity there, and it could be a field. I don't know how long-term it would be, but there is a short-term opportunity. It's what Jeff mentioned. How do you get up the infrastructure to get testing? How do you ensure that you have adequate protection, social distancing? You're really kind of taking a gimbal walk through everything, and you're looking at the picture of what employment used to look like, what it needs to look like to open back up. So Tara, I think the answer to your question is yes. Do I think it's a long-term thing? It depends on how long this pandemic's going on.
Okay, and I think Matt and Dave and Kate and Scott all know, because I mentioned this to them, that I teach international business. So I always want to bring international into this somehow. So I'm going to mention, first of all, that Iceland has reached some degree of infamy for the fact that they're the highest per capita testing nation in the world right now. They've managed to provide the most tests per person in the country of anybody. As a result, their numbers seem to be doing very well. We keep hearing on the news on a regular basis that overall testing is very, very inadequate at this time. So, hopefully there'll be change coming that way. But then we hear about a country like Sweden that actually almost looks like they're seeking a herd immunity. And they're allowing life as normal to continue as much as possible, not closing restaurants, not closing theaters, asking for social distancing, but not enforcing. The one thing they're doing that's different is they're trying to protect their seniors, and they're making a real goal of let's separate the seniors from the rest of society during this crisis. They initially had a big kickoff of numbers, and then they leveled off very quickly and have come back down quite quickly. Their numbers don't look dramatic compared to others. So it was interesting to hear that. Any thoughts on how other countries are handling this, or if these approaches are valid or reasonable, or what your intrigue level is on some of these thoughts?
So Jeff, just a little comment on herd immunity. And so really when you look at major pandemics like this, and you can look back to smallpox, you can look back to Spanish flu of 1918. The way you eliminate the virus is by eliminating its ability to pass from host to host. And you get that with herd immunity. Now, herd immunity for this particular virus is about 70% of the population being immune. Now, there's two ways to achieve that immunity. One is through adequate vaccinations, and a vaccination that has a durable, lasting immunity. One is through exposure. Based upon the case fatality rate of this particular virus, and we don't know it completely because we don't know the denominator completely, one would rather go with waiting for the appropriate social distancing and the appropriate immunization mechanisms to achieve that herd immunity. I think the consequences of achieving herd immunity through exposure, especially for the vulnerable populations like the elderly you mentioned and other patients with multiple comorbidities, I think would be somewhat devastating. So getting to that point and exactly how we get there is probably what's going to get us truly over this hump. I think the jury is still out about can we leverage situations such as Sweden. We have different socioeconomic stratification that may make that more challenging. I don't know what Scott thinks.
I think it was well said, Dave. I would agree with what you said.
I think the key is, even in the US, we have a hodgepodge of responses, right? And at least over there in those countries, it's a uniform response. So right or wrong, it is followed uniformly. We have a little bit more of a hodgepodge because the states are allowed to regulate themselves in a unique situation. And I think even just a much more diverse population that potentially has differing views and differing levels of willingness to adhere to different social expectations under this pandemic.
Excellent, thank you. I do have another question here. I'm not sure who this goes to, so I'm going to read it out and see if one of you wants to take it on. How do you see the system's relationship with pharmaceutical companies changing in the future? Do you think this will impact your access to new medicines and your relationship with sales reps in the future?
Well, I could take a stab at that. Current state, for me, I haven't seen a pharmaceutical rep face-to-face for several years because we are what is that called? I think it's called the Sunshine Law.
Yeah, it's the Sunshine Act, Scott.
Yeah, Sunshine Act, thank you. We're not allowed to accept gifts from pharmaceutical companies. So when that went away, we basically stopped doing, say, lunches or interactive time with pharmaceutical companies. So that's really not been a factor in my practice or my work for quite a few years now. So I don't see it really changing as a result of the pandemic.
I
It's
agree
also
with Scott.
Yeah.
You know, at least for a decade, I hadn't seen one. And it was all based upon the fact that, number one, we did have the Sunshine Act. But whenever a pharmaceutical rep would come in, really what you wanted to see was sound data and sound science. And sometimes they gave you that and sometimes they didn't. And you didn't want to let your practice be offset by that approach. So now they don't come in, and the providers are looking for sound data and sound science to guide them through the right therapies.
And even if they weren't, I mean, I'm not saying that's the case, but even if they weren't, it's something we as a system audit the Sunshine Act data on a yearly basis. So it's something we're cognizant of and want to avoid conflict of interest. So it is, we leverage that data internally.
Thank you. So we're down to the last few minutes here. Does any of you in the audience have a question for our crew? You can raise your hand or you can put it in the chat box and we'll try and get it out to them. Here's one. This is from Isaac Adams. You referred to pandemics of the past, example 1918 Spanish flu. I think it is reasonable to assume that there were pandemics that existed deep into the past of human history and we did not have vaccinations, but we still survived. Assuming we don't go with vaccination route, how can we effectively create herd immunity? Is this what ancient humans did in the past?
My historical depth of knowledge may not go back as far as that. However,
Dave, I don't think he was calling you old. Let's start with that.
Yeah, that's okay. I understand. I haven't shaved during the pandemic, and maybe that has some influence on the way the question was posed. That said, exposure will lead to herd immunity. And in the past, there were exposures. Look at the 1918 flu, the pandemic in 1918. That exposure led to herd immunity. However, there was significant impact on mortality and morbidity. Do we want to accept that in modern day society? I think we're being cautious about accepting exposure leading to the immunity that will lead to herd immunity.
Yeah, I think it's a debate, and it's one that I don't want to get into a political one on, but it is really, you know, the value of waiting this out, the cost of human lives potentially versus reopening, getting herd immunity quicker. You know, it's you could argue so many different sides.
We might need the medical ethics community to help us out with that one.
Yeah, I was a math major, not an ethics major. So.
Any other questions? If not, I'm gonna really thank our group here. Thank you so much for joining us today. Exactly the type of conversation we were hoping for, learn a little bit about what's happening and maybe a little bit about where we're heading. We really thank you for sharing your time and for joining us. I love the view at Dave's background there. It makes it look so pleasant to be affiliated with RRH. Not that your homes don't look nice, Matt and Kate and Scott, but I'm just saying that has a very pleasant appeal. That's Tallinn, Estonia behind me. Matt joined us there last year for our international trip. So if you don't know what that was you're looking at, that's where you're seeing is Estonia. For everybody that joined us, thank you for coming. We'll start getting something out about what next month's topic will be. Again, RIT's Executive MBA program, this is the kind of stuff we do want to talk about on a regular basis. Keep you engaged and informed. So thank you for your time. I'm going to stick around for a minute. I think a few of the panelists may as well. So if you have a question, stick around and we'll try and answer it quickly.
Yeah, and Jeff, thank you for the opportunity.
Yeah,
Yeah,
thank you.
thank you.
Thank you for having us.
I'm good to hang out for like 15 minutes or so if there's other questions.
Okay. We're just hearing some thank yous. Scott Strother, Lynn Mall, Isaac Adams, Anthony Smith. Thank you. Thank all of you for being here.
It's much appreciated. Thank you for showing up. Hi, Jason.
Godfrey didn't speak, but I'm going to call him out anyways.
He's one of your classmates.
He is.
How's it going?
Good. How you doing, Jason?
I'm doing good. Good call.
Jason and Kate used to work together. They were on the same team.
Oh, nice.
Yep.
Well, nice for Jason. I don't know if it was nice for Kate.
That was very nice.
Definitely not.
I'm just teasing him.
All right, I gotta go.
Hi, Jason.
See
Bye,
you later.
Jason.
Just wanted to say thank you guys for your time. Appreciated it. Hope you guys all have a good day and stay safe.
Great to
Thanks,
see you.
you too, Natalie.
Thank you,
Be
everyone.
safe.
Bye.
And I don't know if anybody's posting questions, so we may be just about there.
It looks like we're getting a dispensation here, Jeff.
There you go.
It's
Thank
the
you.
herd immunity from questions.
Oh, I love it.
It's Scott Strother. I did ask whether you guys see biotech reps in the same sort of light as pharma reps, like they haven't been coming out, you haven't seen them in years. Does that sort of apply to them as well, pharma and biotech?
So from biotech in the OR, because we use biotech in the OR, on demand, if there's a product that we need technological from the design perspective assistance with, we will request it, but it's not the other way around.
They used to be there
Thank you.
at the elbow all the time, right, Dave?
They used to be at the elbow all the time, whether you wanted them there or not, and that really wasn't appropriate. I think it's a derivation of pharma. There are times when they can bring things in that we don't necessarily have in stock that are new products that we are well aware of how to use. We've been trained in how to use, but it will be as we request them to come in and not the other way around.
We have another question here on the status of plasma injection from recovered patients.
So who asked that? I just want to see if we could
Marjorie.
clarify it a little bit further.
Marjorie Perlman, it came privately to me.
Okay. Marjorie, do you mind unmuting yourself and elaborating? I'd happily have any of us answer. I just want to make sure we get at what you're specifically curious about.
Okay, I'm actually asking, whoops, I'm asking for my husband, who's sitting next to me, who's an RIT emeritus faculty in electrical engineering.
Hello, Marjorie's husband.
Well, I did try to send it to everybody and it didn't go. So then
You're wasting time.
I could send it to Jeff, and I thought he's the moderator. He'd know where to send it.
No, I know that there's been some indication that if you take the plasma from that hopefully has antibodies in it and inject it into somebody who is already sick, that you can help them recover. You're taking the plasma from somebody who has already recovered.
Mm-hmm. And I'll answer one thing and then I'm going to defer to the clinical experts because I do not have a medical degree. But we're trying to get testing out there to see who has antibodies. And I know we've started that up as a system. So it's something we're actively pursuing for just that reason. But the medical and the science behind it, I think I'd be better suited to punt that question over though. Dave or Scott?
Well, I can comment on it briefly. So that's called immune plasma. So after someone becomes exposed and immune and recovers and has negative tests, then they will have an antibody test. And if they have antibodies, that antibody has been tried in very carefully controlled settings. Their plasma has been used with their antibodies to help treat patients in extremis. I do believe it's one of the therapies we offer, but that would probably be a better question for an intensivist than either Scott or myself. Scott, do you have anything to add to that?
No, I would agree. It's, for the intensivist, and I would agree that would be when everything else is failed or, just being tried in very specific situations at this point.
Because Scott and Dave, my understanding is this, and please correct me, but the goal is, it's a Band-Aid, right? So it's antibodies in your system until your system can hopefully develop further antibodies, because this is not a way to jumpstart antibodies. It's almost like a lifeline until your system does potentially, correct?
Right, correct. And think, we've used it in other circumstances. Scott, think of tetanus immune globulin.
Sure.
If someone hasn't been vaccinated for tetanus and comes in after being exposed to tetanus, we will give them tetanus immune globulin, which are antibodies that are cultured on behalf of that to prevent that, but it is not a long-term strategy. It is a short-term, I like that Band-Aid, Matt.
But it buys time while you're still working on vaccines. It could be something.
True, it does, but the only problem with that as well is right now it's derived from human plasmapheresis, so it's not extremely scalable.
And I think to Scott's point, we try to save it if other efforts aren't working. But yeah, we're as a system looking at who's potentially had it, and then the look for donors for the plasma as well. So it is something we are utilizing. It's just not, as Dave said, very scalable.
Well, every recovered patient is so thankful to be alive. I should think he would donate the plasma.
Oh, we would love it.
We totally agree with you.
Go ahead.
I was just hoping to kind of like expand on that question a little bit more in terms of, you know, developing herd immunity as it relates to whether we're using vaccinations or plasma or whatever other techniques are medically and scientifically available. And I'm just thinking about that because, you know, I think vaccines in this day and age are just getting a bad rap amongst people in general. And
Do you think social media has a play in that?
Absolutely, absolutely. And I think that is expanding, you know, just from social media and the bad raps that vaccines have gotten from, you know, potential associations with autism and things like that. So I'm just concerned that even if it's available, there might be a substantial amount of the population that simply won't accept it. And so then where do we go from there? So
You're absolutely right. There might be a certain percent of population won't accept it. And whether that's right or that's wrong, let's not pass judgment on that part of the population. The theory behind herd immunity is not 100% of a population has to be immune. If there are 3 people in a room and one person has the disease and the other 2 are immune, then you can't pass it. And if all you ever have are those 3 people in the room, then that disease would die out. And that's the theory behind herd immunity. And for COVID, we're looking at about a 70% immunity rate.
Which is much different than MMR, right, Dave? Which has, you need a much higher herd immunity?
Yeah, different viruses need different immunity rates. Correct.
And my experience has been the vast majority of the patients I've seen over my 25 years in medicine do accept vaccines. They do get their children vaccinated. As adults, they accept influenza vaccines. It's a very, very small portion of the population that refuses these things or says, well, I'll get part of that combination vaccine for my child, but I don't want this one. Even though there's press about it and it is definitely out there, it is a very small portion of the population that refuses these vaccines, you know, across the board.
Okay. Thank you so much again for your time. We really appreciate it. I know you've got to get back to work.
Stay safe, everyone.
Everybody stay safe
Thank
and stay
you.
healthy.
Really appreciate it, guys.
Bye.
Thank you. Bye.
There we go.